Good evening, everybody. Today is Sunday, October 23rd, 2022. Today is a case list defense webinar. We'll be going till 10 o'clock tonight. So we're just going to jump right into it. See if anybody wants to volunteer to be on the hot seat. All righty. Priyanka here. Are you there, Priyanka?
Hello. Yes, I am. Can you hear me?
Yes. How you doing?
Good. How are you?
We're good. How about yourself?
I'm good.
You're an MFM fellow, correct?
Yes, ma'am.
So what are you looking for? You want a case?
We could do a case or anything off the office list. I feel like there's plenty of office topics that, they could still dive into from my office list.
Are you looking for a specific case or just anything?
Just anything.
Okay. I'm just looking at it, okay?
No worries. Thank you.
And of course, you have a lot of OB stuff.
Yeah. So that's why I think I was concerned.
Trying to think of something that, Case number 12.
Okay. Good.
Can you discuss for me the counseling you undertook with the patient in regards to the treatment for her abnormal uterine bleeding?
Yes. This was actually one of the cases I forgot that I did want to review, so that's good. This patient had presented 6 weeks postpartum, and she had a known history of abnormal uterine bleeding prior to her pregnancy and dysmenorrhea. And previously, she had tried OCPs, obviously, before she was trying to get pregnant and with this pregnancy, and always had painful periods and still always had kind of just spotting in between her cycles and things of that nature. So when she came in for a postpartum visit, we talked to her about her different options. She was still breastfeeding, so we told her we would recommend avoiding things with estrogen and just doing progesterone only things, such as like the Micronor progesterone only pills, the Depo shot versus LARCs, the Nexplanon and the IUD. Given her abnormal uterine bleeding in the past, she opted for the IUD. We counseled her that, the 1 year rates of like amenorrhea are approximately 20 to 30%. 20 to 30% of women will say they have lighter periods if they don't have amenorrhea a year out also. And some people, their bleeding pattern won't change. But given that, she decided that it was kind of worth a shot, really, and she didn't want to have any children in the near future, so it was kind of to help with her bleeding and a good form of contraception for her.
So what are causes of abnormal uterine bleeding?
So causes of abnormal uterine bleeding could be broken down into structural causes and non-structural causes. So for structural causes, you could be thinking about like polyps, adenomyosis, leiomyomas, malignancy. Non-structural causes, you could be thinking about like coagulopathy, ovulatory dysfunction, iatrogenic causes, endometrial causes such as like endometrial cancer, and then things that we may not quite know yet. So sometimes they can be identified as like not otherwise specified.
What do you mean by endometrial cancer on the E?
For E, I mean, you can have EIN versus adenocarcinoma of the endometrium.
Wouldn't that be under malignancy?
I guess yes. Well, I think adenocarcinoma would be, but EIN would not necessarily be under malignancy. EIN could be, in the olden terminology, they would call it just hyperplasia, you know? So about 40% of cases of EIN at the time of hysterectomy are identified as malignancy, but it is not necessarily malignancy. It's a possible precursor.
Can you give me an example of non-otherwise specified?
No, I think it would be one of those things that if you've gone down, you know, your differential and you've ruled out all of the things that I've mentioned, sometimes you may not know exactly what's causing the patient's bleeding. And
So you
you know,
said,
you could,
go ahead.
I was just saying, and maybe you say it's not otherwise specified while you're still continuing your workup to see if you can find an etiology.
But you can't think of anything that would qualify for not otherwise specified.
I mean, I guess I don't know if this would actually count, but like if you're bleeding in pregnancy, I suppose that would not be part of the other differentials I have said. So, you know, abnormal uterine bleeding in pregnancy from like a previa, for example, potentially, but I don't know if you would put those things together.
So you said the recommendation of LARCs. So the subdermal implant, what does it contain?
The subdermal implant contains, I believe it's a form of progesterone.
Specifically.
I am not sure. I think it's the Levin. No, that's the IUD. It starts with an E. Tonorgestrel. I'm butchering the name.
Do you know the dosing
Of the implant? No, I do not. I would have to look that up.
in regards to the IUD? What are contraindications to the IUD?
Contraindications to the IUD. So there's different types of IUDs. So if you were to use the non-hormonal copper IUD, if you had Wilson's disease or if you had an allergy to copper. Otherwise, if you had an abnormal uterine cavity, such as like if you had submucosal fibroids that were impinging on the cavity, or if you had like a bicornuate uterus, those would be contraindications to placing the IUD.
Anything else?
Allergy. I'm trying to think. Those are the things that I can think of at the moment.
Now, tell me specifically the different types of IUDs and their pros and cons.
So you have the hormone IUDs, so like your Mirena IUD, versus your copper IUD, which is going to be your non-hormonal. As I mentioned, some of the pros of using a hormone IUD, there is the possibility of having amenorrhea at some point versus like having lighter cycles versus with the non-hormonal, that's often not going to happen. Sometimes people will say that their bleeding pattern is actually more than kind of what they were initially used to. And then with the hormonal IUD, you do have different types. So you have the Mirena and the Liletta, which are going to be 52 milligrams, and then the Skyla
Exactly.
and
What do they contain?
sorry, I'm really bad at saying names. The levonorgestrel. I'm saying it wrong.
Okay.
And then you have the Kylena and the Skyla. And
so let me ask you this. You have the Mirena, you have the Kylena, and the Skyla. Why do they have so many different IUDs? What's the benefit?
Their size is different. So I believe the Skyla is a little bit smaller. So in patients that have never been pregnant before, sometimes they'll say that it decreases the pain during insertion. And it's a little bit more tolerable for some people. And then I believe between the Mirena and the Liletta, the difference is the biggest difference is the cost to the patient.
What do you mean by cost?
At least at our institution, and this may be different and varies, but we often don't do the Mirena over the Liletta because insurance purposes, it's much cheaper for the patient to do the Liletta. We'll offer them both and we'll run their insurance and tell them the cost. But most patients will opt for the Liletta.
Now, of the IUDs that you've mentioned, which one has the highest amenorrhea rate?
I believe the Mirena has the highest amenorrhea rate after 1 year,
Can you tell me what that rate would be?
about 20 to 30%.
And then what comes next?
What do you mean? I don't understand the question. I'm sorry.
The next for in regards to amenorrhea rate. So you say the highest is Mirena. What would come
Oh,
next?
okay. That is the only one I specifically know of. If I had to guess just based off of the levels of hormone in the IUDs, I would say the Mirena is the most, the Liletta is after, the second most. And then I am completely drawing a blank between the Kyleena and the Skyla in terms of their doses, but the Skyla, of the three that we had initially talked about, I would say the Skyla would be the least likely to cause amenorrhea.
Do you have a rate?
I would be guessing if I gave you numbers for those other two.
Okay. And do you know how much the Skyla contains in regards to levonorgestrel?
I want to say 19.5, but I'm not sure if that's the Skyla or the Kyleena. I'm like mixing them up in my mind at the moment.
Can you describe for me how you place an IUD?
Yes. So for this patient, we did place a Mirena IUD, and what I will do is initially, first I do a good pelvic exam, make sure the patient doesn't have tenderness, anything of that nature. We'll insert a sterile speculum, clean the cervix with chlorhexidine or betadine if the patient, has an allergy. And then, goodness, I haven't placed it in a minute. And then I take the IUD and I essentially will gently use it to sound the uterus and see kind of where it goes to the fundus, and then come out and then adjust my notch. Actually, no, I don't do, yeah. And then adjust my notch. And then when you're placing the Mirena, there's like different buttons, like you insert a little bit and then you let the arms deploy. And then once the arms deploy, you need to go back and insert a little bit more to make sure you're at the fundus, and then release the IUD. And then afterwards, I cut the strings about 2 centimeters.
Can you tell me how you put in a Paragard?
So to put in a Paragard, you'll initially need to prep the actual IUD. So you'll need to put the arms into essentially the circular cylinder yourself. And then I do it in a very similar fashion in where, I obviously prep the patient, speculum's in, I will sound the patient, and then seeing where it goes to, I will put my Paragard in, release, and then make sure I go back up to the fundus.
How do you release it?
To be honest, I would have to look that up. I have not placed a Paragard since residency.
All right, we'll stop there. What'd you think?
A lot of IUD questions I do not know.
It says IUD placement.
Yeah.
It's on your list.
Yes, it is. And this was, I think, what I needed.
Up, did I? It's there.
Sorry?
And of course, I'm picking on you because I know you're at MFM.
Mm-hmm. No, but I think this is the part of my office list that I need to kind of realize is like, this is, these are the questions that are going to be pulled from my office list, for example.
So in regards to the palm coin, your polyps, adenomyosis, leiomyomas, malignancy includes EIN, coagulopathy, ovulatory dysfunction, endocrine.
Oh, endocrine. Okay.
Not endometrial. Iatrogenic and not otherwise specified. What I think of not otherwise specified, I would think of like an AV malformation.
Oh, okay.
That's what I read that once. I went, oh, okay, very nice.
That makes sense. Thank you.
All righty. The Nexplanon contains etonogestrel, 68 milligrams. Can you tell me its mechanism of action? I didn't ask you that.
Yes. Oh goodness. I believe it thickens the cervical mucus as its primary, and then it prevents ovulation. Also.
The primary is preventing ovulation, prevents the LH surge, And then the secondary causes is the thickening of cervical mucus and
Okay.
the endometrial environment not being conducive for sperm or implantation, for lack of a better word. But that's kind of later, you know,
That's second. Okay.
tertiary and whatever. Usually in the first 2 years, it works really well for decreasing the chance of ovulation. However, that starts decreasing the longer you have it in place. So then the secondary effects come into play.
Okay.
That makes sense? That's what
Yes,
the package insert says. Contraindications to IUD, severe distortion of the uterine cavity, active pelvic infection, pregnancy, unexplained abnormal uterine bleeding, Wilson's disease because of the copper, current breast cancer. You got your Paragard and you have your progestin containing. They all contain levonorgestrel. Mirena contains 52 milligrams. It's good now for 8 years for contraception, 5 for abnormal uterine bleeding. Amenorrhea rate of 20 to 40%. Same thing with Liletta, 20 to 40%. The Kylena lasts for 5 years. To my understanding, that has not changed. 19.5 milligrams. It contains a levonorgestrel. It has an amenorrhea rate of 12 to 20%. Skylus for 3 years, 13.5 milligrams with an amenorrhea rate of 6 to 12%. Personally, I would not, this is my opinion, I would not sound the
copper.
uterus with the IUD
Okay.
mechanism. In the old days, which I don't have anymore, they don't do it anymore. In the old days, the Mirena IUD came with a little plastic sound that was sterile.
That's what we used to use. Yes. Okay.
Okay, because you want to keep that as sterile as possible. You don't want to keep putting that thing in and out.
Right.
So you go to the fundus, pull back a little bit, release it, go back up lightly to the fundus, and then you push it all the way out and the strings come out and you trim them. The Paragard's a little bit different. It's actually harder to place in the sense that if you have a very small os, when you put the arms in the little transducer, it like sticks out. So it makes it a little bit more difficult, especially if somebody's never had a baby or only had C-section. So the os is a little bit on the closed side. And that one you actually have to hold the little I don't know if you remember, there's this little rod with a little circle on it. You pull that tube out towards you, and that, for lack of better words, opens the arms. You don't push it in, you'll pull it out. I don't know. You'd have to look at the package insert.
Okay.
Because you'll see it, and it's completely backwards in the Mirena. Completely backwards.
Yeah, I'll definitely look into that and make sure I know.
I mean, I haven't put a Kylena or a Skyla in several years, but it's similar to the Mirena. And I've never put in a Liletta. I've never even seen one. I've never worked in a place that has it.
Yeah, they are. I've done a Liletta a few times, and they are very different than the Mirena. We'd only did Mirena in residency. It's a learning curve.
Alrighty, so other questions? I think that covered everything. I mean, it's all about, abnormal uterine bleeding and then the different medications that you can give. And it's limited in the sense that you clearly explained in the beginning that, progesterone only, blah, 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 blah.
Okay. Yeah, this one, I just wanted to make sure they were okay with the fact that, like, normally at 6 weeks postpartum, it's not abnormal uterine bleeding, that we're not going to call it that from the 6 weeks. It was just that this patient had
I guess you could have written history of.
Okay. Right.
But you said in your explanation that she had this history before she got pregnant. So it's cool.
Okay, so
plus it helps her with her contraception.
Right. Perfect. Thank you so much.
But another thing I just saw, you have it under endometriosis, diagnosis and office management. So are you assuming she has endometriosis because of the dysmenorrhea? I didn't
Yeah, so
realize
one
that.
of her previous GYN doctors had put that she had
but how do you diagnose it?
Dysmenorrhea was secondary to endometriosis, and she had abnormal uterine bleeding. She tried OCPs kind of for both, and it didn't work. And so
it was an assumed diagnosis.
Yeah.
She has not been taken to the operating room. So just be prepared to discuss that, how do you diagnose endometriosis?
Right, with pathology.
Exactly. Or visualization, however you want to describe it. You see the buckshot or whatever. So it's an assumed, I'm just looking at the top of the category.
Right. Yes, ma'am.
It's an assumed. So just be prepared to discuss that. Because remember, REIs and very seasoned generalists test your office. Okay.
All right. Thank you.
Other questions? All right, very nice.
Thank you.
Alyssa, I'm going in your direction. Says you're self-muted. Are you there?
Hi, can you hear me?
Yes, how you doing?
I'm good. How are you?
Very good. You're a generalist, am I correct?
Yes.
You don't sound so excited. You want a specific case? What are you looking for?
Any of the cases, and we can keep going in a list, GYN or OB.
Okay, let me go find your list here.
Um,
Any specific case that concerns you?
I have on my GYN case a couple patients who had,
Okay.
let me see if I can find them quickly. If not.
What section?
They are part of management of vulvar disorder. So I had 2 labial abscesses that I ended up draining in the OR, but it was kind of a bit of like they were admitted with other people for a while and that kind of stuff. So maybe if we could just like go through that and how I can describe sort of what we did and, you know, also go over the recommendations.
All right, so there's case 22. You want to present it?
Sure.
You want that one or the other one, the one above it? You're good with 22?
They're honestly very similar. So case 22, this is a 36-year-old G0. This patient was admitted through the ER for a history of recurrent vulvar abscess. She had been status post IND in the ER and oral antibiotics ×2, but continued to have recurrent.
Can I interject here? Does
Yes.
she have a particular history medically that would predispose her?
Not,
And if so,
not that we knew of
what would
other
you worry
than
about?
obesity. Her BMI was 40.
Okay, anything else that would worry you?
We, at the time, she didn't have any, you know, like STI testing or any diabetic
So
paneling.
let me interject here. You're saying STD would lead to labial abscesses? In what way?
If somebody was immunocompromised, like with HIV or something like that, I would be concerned that they would be having this recurrent infection, or if they have a history of like diabetes or something like that,
Okay,
where they.
and was that checked for this patient?
It was, yes. So the
And it was
patient
negative.
hemoglobin A1C that was normal, as well
Okay.
as an HIV
So what's
serology that was
normal
negative.
for hemoglobin A1C? What's normal?
Less than 5.2, I believe, is considered normal. Between 5.2 and maybe 6.5 is pre-diabetic, and then greater than 6.5 is considered diabetic.
Okay, continue.
So the patient was initially admitted to the medicine service, was started on IV antibiotics.
What antibiotics?
She was started on Unison and clindamycin at the
And why
time.
was she, do you know, I know you may have not started it, but why do you think they started those 2 antibiotics?
I think just considering broad coverage, given her recurrent, the recurrent nature of what she had.
So the Unison would cover what?
Unison should cover, I believe, gram positives, as well
And what
as,
you said, clindamycin?
yeah, clindamycin. That should help cover some anaerobes.
So were they missing something, you think, in your opinion, in regards to the antibiotic
Yeah,
choices?
I don't believe that either one of those covers like a MRSA well. That's usually would be a vancomycin that comes to mind.
Continue.
Laura.
You there?
Yeah, can you hear me?
Oh, okay. Yep. Okay, so she got admitted to medicine, and then what happened?
And then she was admitted for 24 hours without improvement, and then we were consulted.
Now, are you surprised that how big was the abscess?
So the abscess ended up being about 3 by 3 centimeters when we looked in the
And,
OR.
and are you surprised she didn't improve on the antibiotics alone?
I mean, usually if it's less than 5 centimeters, I believe that you would well, no, at 3 centimeters, yeah, I wouldn't, with an abscess, I wouldn't expect that alone to.
Does she shave in that area, wax in that area?
Um, Shave, I believe.
Okay. Could that have been an issue, you think? Like, why is
Yeah,
she getting these
definitely
recurrent?
yeah, it would increase the risk of something like a folliculitis or, a abrasion that could have become a abscess.
Okay. Continue.
So the patient was very tender on exam, very limited exam, but just given the fact that now she had not improved on IV antibiotics and had
So when you say, let me interject here a second. So when you say left labial, by the mons, in the middle,
more like central, not just kind of above where you would think of a Bartholin's gland. So it wasn't
but it
quite
wasn't a Bartholin's.
It was not, no.
You really don't shave in that area, correct?
No.
Okay, continue.
So exam was limited due to pain. So decision was made to proceed with an exam under anesthesia and drainage of this kind of presumed vulvar abscess. So the patient was brought to the OR. She was, and that was where we were able to do a better exam, and we found a 3 by 3 centimeter fluctuant area consistent with an abscess on exam. This area was then drained. We did take fluid for culture. The area was kind of copiously irrigated and then packed with iodoform gauze.
And was the, because it grew that Anaerococcus murduci, never even heard of that.
Yeah.
So an anaerobe, was it pan sensitive?
Yes, it was. So initially the patient was on. So she was transitioned over to Augmentin and Bactrim orally.
Why was she transitioned to those medications?
Just because her overall clinical picture was improving after
Right, because you drained it. But why Augmentin and why the Bactrim?
The Bactrim helps cover for skin flora, and then the Augmentin helps cover.
But did the sensitivities return?
No, we switched her over to those before we got them back, before we got the antibiotics.
Any particular reason why the Bactrim was chosen?
Just for skin flora coverage and MRSA
more
coverage.
Specific MRSA coverage. Okay.
Yeah.
But it was pan sensitive. It was nothing else.
No. And so it came back kind of with this abnormal bacteria, and after speaking with ID, we were able to just continue the Augmentin and Bactrim as it, covered this anaerobic atypical bacteria.
Did they have any recommendations on why the recurrence? I'm talking about ID.
No, not quite. The patient, I think, had maybe some issues with like hygiene and potential compliance with the antibiotics that she was taking, so that may have contributed to it.
So you brought up it was close to the area of the Bartholin's. So how would you perform a marsupialization?
So for marsupialization, you're going to sort of identify an area of the Bartholin's gland that's kind of a little bit more taut and firm. Then you're able to put I always do a vertical incision or a cruciate incision, so kind of up and down, side to side, to drain the Bartholin's gland. And then you want to open up that area. So using usually like a smaller stitch, like a 3/0 Vicryl, something that's not going to bother the patient. I do stitches usually at like 12 o'clock, 6 o'clock, or 3 o'clock, 6 o'clock, and 9 o'clock to try to evert the edges, to open them up, to try to allow a track.
So you said you're everting the edges. Is there anything more specific you need to do?
I mean, you're sort of taking that cyst, the gland wall, and everting it out so that it doesn't.
Okay, so the cyst wall. So you grab the cyst wall and suture it to the edge. Is that what
Yeah.
you do?
Yes. Yeah, to make a tract form, essentially.
Okay. And branches of what vessel could be damaged and lead to heavy bleeding if you were going to remove the Bartholin's, excise it?
I want to say the pudendal artery, but I am not positive about that. It's something I would have to confirm.
You're correct. It is pudendal. So very good. But you would get partial credit. I don't know if you get full credit because you said you weren't sure.
I should have just went for it.
Yeah, but if you were all wrong, right?
I know.
But don't forget when you do your marsupialization, the key is to get the cyst wall, and that's what you're suturing.
Okay.
Okay? A lot of people don't say that. They say, well, I invert the edges. Edges of what? It's the cyst wall. So you have to have a very, very, very light hand because you don't want to lose the cyst wall because that's the point of it. Yeah, I think the presentation was fine. I would know something about this culture because I've never heard of Anacoccus, whatever that is. Where can you find it? I'm assuming it's an anaerobe just by its name. I mean, the Bactrim, mainly the Bactrim would be probably for MRSA.
Yeah.
You know, that's what you need it for. But, you know, you said she was pan sensitive, so you could have probably discontinued it and augmented would have been sufficient. But, you know, you brought up HIV, you brought up diabetes. You know, I just said, well, maybe, you know, does she shave in that area wax? That could maybe make that area a little bit more of an issue if you had folliculitis. And kind of weird to have it in that particular area. I've seen it more in like in the mons with diabetics, like bad abscesses. But realistically, I mean, an abscess is not really going to heal at that 3 centimeters if you don't IND it. Let's be honest.
Yeah, because so it's usually less than 2 centimeters. You can just observe.
You know, I mean, I've seen I've seen patients, they'll come in with a little folliculitis. Oh, I have this. I go, you know, it'll cause more harm than good if we IND this. It's so little. I'm talking about like not even half a centimeter.
Yeah.
You know, I mean, there's nothing you could do about it. That should resolve. With something this big, you know, I mean, obviously she didn't get better, right?
Yeah.
So I'm sure she had cellulitis too on the skin.
Yeah.
So,
that was as well.
No, but yeah, I think it's a straightforward case.
Okay.
You know, I would know stuff about antibiotics really well, and then the organism that grew.
Well, thank you. Yeah.
All right. Any other questions? Very nice.
That's all.
Right. Cool.
Thanks.
All right. Oh, I got a question here. Let me see. Oh, so I have Hannah here saying that in ACOG, the practice bulletin, the E can be endometrial. Oh, I always known it as endocrine. Interesting. I know that Up to Date says that. Ooh, would you be able to give an example of that type of pathology? Ooh, I'm gonna have to think on that one, Hannah. You know, because it's not, you know, EIN, that's gonna be under hyperplasia. Adenomyosis is a separate thing. How about an endometritis, a chronic endometritis? Oh, yeah, Janelle is writing it as I'm thinking, I'm looking out into space thinking. So Janelle's saying endometritis, Alexandria saying atrophy. I think endometrial can be infection or inflammation. That's from Eva. I usually say endometritis for the E. That's Emily. Up to Date also says endometrial for E. Oh, I remember the last time I checked Up to Date, it said endocrine. I think it has to do with release of prostaglandins in an endometrium. I believe so, Elizabeth. Okay. So excellent. Very nice. All right, Alexandria, I'm coming in your direction. Are you there?
Hi, can you hear me?
Yes.
Okay.
So you're REI, correct?
Yeah.
You don't sound excited. So you're looking for OB, right?
Whatever. Yeah.
What were you looking for?
Anything.
A specific thing in your case list?
You can just choose whatever you want.
You pick the what you would like. I could care one way or another.
Yeah, I guess we could do OB because I'm bad at OB.
You're bad in OB? All right.
It's been a minute.
And you're in fellowship right now?
Yeah,
Okay. When do you finish?
in a year.
Cool. You're gonna be making the big bucks, right?
Hopefully.
Making the big bucks. Think of the little people like myself. So you're gonna hate my guts because I'm gonna go for the jugular here.
Oh my God. Okay.
That's the first case.
Oh Jesus. I can't even remember what it is.
All
Wait, we
right.
actually did this. I actually did this one.
You actually did this before?
Like the only other time I was on the hot seat, we did this one. Yeah.
Talking about breach. Damn.
Yeah, breech delivery, and like
Well, I hope we did well.
the person went in on me, so that was fun.
Oh, they did?
Yeah, no, it was constructive, but
Okay. I don't know if this one will be constructive, but let's see. So case number 7. How do you diagnose arrestive dilation?
arrestive dilation can be diagnosed in a patient who is 6 centimeters dilated and has not progressed for 6 hours in the absence of adequate contractions and 4 hours in the presence of adequate contractions.
So what's adequate contractions?
200 Montevideo units measured over a 10-minute course on TOCO.
How do you calculate that?
You physically go to the room and look at the strip and calculate how many.
So you have to do something before that.
You have to
something have to be.
IUPC prior, an internal patient, and then you count the pressure for each contraction during that 10-minute interval, and you add it up.
So what is the Bishop score?
The Bishop score is a score that helps you assess if a cervix is favorable for induction. There are 5 categories ranging from.
Let me interject here. What are you looking for specific? Like, what does the score specifically tell? Like, what score are you looking for?
You're looking for a score of 7 or above, and if they are 7, then they are equivalent to being a cervix that is in spontaneous labor.
So the cervix is the same as if you came in spontaneous labor. Can you clarify that a little bit more?
The chances of delivery without cervical ripening would be equivalent in those circumstances.
To a vaginal delivery?
Yes.
Now, this patient was induced. Can you tell me some different induction agents, pros and cons?
Sure. You can use misoprostol, which is prostaglandin E2. Pros are that it's cheap, it is effective at cervical ripening. Cons are that it has a long half-life and typically it's hard to be removed. It can also cause uterine tachysystole and aberrant fetal heart rate.
What's the definition of tachysystole?
Greater than 3 contractions in 10 minutes.
And in regards to the misoprostol, what would be some dosing?
Typically in my institution, I use 25 micrograms every 4 hours.
Route of administration?
It can be given vaginal, rectal, oral.
So you would give it rectally?
No, not for an induction
patient.
labor.
I'm talking about induction or labor.
Okay. I use it vaginally.
Any contraindications to its use?
Prior uterine scar greater than 28 weeks.
Anything else induction agent wise? Pros and cons.
Yes, there's oxytocin, which is given IV. Pros are that it has a quick onset and quick offset, so the infusion can be stopped. Cons, I guess, are that it also could cause tachysystole. However, if you stop the infusion, that can resolve pretty rapidly. Also, there is intrauterine balloon. I use a Cook catheter. Pros are that it's a mechanical cervical ripening agent. You can deflate it easily when you need to. Cons are that it could cause rupture of membranes or potential bleeding if it comes in contact with the placenta. And it can be expensive.
Anything else for induction?
I've never personally used Cervidil, but Cervidil is a prostaglandin as well. And pros in contrast with misoprostol that it can be removed. So if you do have uterine tachysystole, this is easier to remove from the patient in comparison to misoprostol.
So if you have, let's say you have misoprostol and you have tachysystole, how would you control that?
I would start by giving the patient the IV fluid bolus, and I can give her a tocolytic agent.
Such as?
Terbutaline.
Can you give me the dosing, route of administration?
Sure. I believe it's 250 milligrams subcutaneously.
And how often can you give them medication? Go ahead.
Sorry, I said you could also give nitrous oxide.
Why nitrous oxide?
Why would I give that? Because it can be given sublingual. It's painless to the patient, and it's what we have accessible on the labor floor.
So nitrous oxide are they using the nitrous oxide on your floor for analgesia?
Oh my gosh, I'm sorry. I'm not putting the patient to sleep. I'm sorry. Nitroglycerin.
So why would you give nitroglycerin to a patient as a tocolytic?
Because to my understanding, it relaxes the smooth muscular contractions that are propagating the uterine contractions.
But is nitroglycerin considered a tocolytic?
I use it as such in my practice.
Is that a truthful statement?
Yes, we give it sublingual. We give 1 to 2 sprays. I believe each one is 50 micrograms.
Is there other medications you give as tocolytics?
Like I said, terbutaline. I think magnesium could be used as a tocolytic. That's all I can think of right now.
Anything else? You're missing one.
I can't. I probably know it. I'm just not thinking of it right now.
So, how do you diagnose gestational hypertension?
Elevated blood pressures after 20 weeks in pregnancy.
How elevated?
Greater than 140/90.
And then what's the difference between gestational hypertension and preeclampsia?
Preeclampsia would be elevated blood pressure over 140/90 after 20 weeks with proteinuria.
So how much proteinuria?
+2 on a dipstick, a PC ratio of 0.3, or 24-hour protein of 300 milligrams.
So when should somebody with gestational hypertension, I guess if somebody had gestational hypertension, how would you manage this patient antenatally?
I would see her more frequently at diagnosis. At the time of diagnosis, I would get baseline preeclampsia labs to evaluate for the eventual development of preeclampsia. I would have her keep a blood pressure log. I would counsel her on signs and symptoms of preeclampsia. and I would bring her in for antenatal testing 2 times a week and deliver her at around 37 weeks.
So why was this patient delivered at 39 and 5?
She was an elective induction of labor at 39 and 5 due to her work schedule, and she was diagnosed with the gestational hypertension intrapartum.
And in what way? What criteria did she meet?
She had elevated blood pressures 4 hours apart.
Like when she first walked in?
Yeah, when we put her on the monitor and the first set of vitals were elevated, and we monitor her blood pressure serially, and after 4 hours she still had elevated blood pressures, and this started before the onset of her pain or contractions or anything like that.
What are severe range blood pressures?
160 over 110.
So how would you manage that?
If someone had a severe range blood pressure, I would give rrBSO 20 milligrams IV and recheck it in 10 minutes.
Say it's still elevated, what would you do?
I would give her 40 milligrams and check it in 10 minutes.
Still elevated.
Give her 80 and check it in 10 minutes.
Still elevated, what would you do?
Give her hydralazine 10 milligrams. Check it in 20.
And let's say it's still elevated.
At this point, I would consult either maternal fetal medicine or the hospitalist team for co-management.
And what's the maximum labetalol that you can give?
I believe it's 2,400 milligrams in 24 hours.
How about hydralazine?
Hydralazine, I would have to look that up, but I typically give it in doses of 5 and 10 milligrams IV.
And in what situation, if any, would you start with hydralazine before labetalol?
If someone had like bradycardia at baseline, I would give someone hydralazine.
All right, let's stop there. What'd you think?
I'm sweating.
You did very well.
Thanks.
Nitroglycerin is a uterine relaxant. I don't know if I would give a uterine relaxant to a woman who's still pregnant.
Oh, we give like Janelle, who's on the webinars, my
Yeah.
co-resident, we used to give it in like this little red bottle, and it's a spray that goes under their tongue.
Oh, I've never seen that. I mean, I give it if I got a head entrapment in a breech.
Okay.
Dude, wow, I don't know. I mean,
Yeah,
I was thinking that for me, tocolytics is nifedipine,
Yeah.
TERB. We're not supposed to do MAG anymore.
Yeah.
Look, is Priyanka still on the call here?
I don't know. As an
She's
intern, in our pocket.
I know she's an MFM. Let's ask her. Oh, she's raising her hand. I'm trying to unmute you, Priyanka. I mean, maybe I'm learning something new today, but I don't know if I would want to give a uterine relaxant with a baby inside. You're there, Priyanka?
I'm here. I agree with you. I mean, I've never given it while a patient.
I mean, I would be very. The baby would get no blood.
Right. I mean, it would literally be kind of in the last, like, a head entrapment for a twin. It's kind of where my mind would go.
Yeah, exactly. Dude, I don't know. It's news to me.
Okay.
I'm willing. I wouldn't do it. I would not do it. I'd be so scared that something bad would happen to the baby.
Okay.
I'll do it maybe if I'm doing a section and I have a bad entrapment. I've seen that happen before. Like, you know how you have like a 27-weeker and the baby just gets, I mean, they rupture and the baby's like stuck in there and you can't get it out. It's like a transverse lie. And you even did a classical and you can't undo it. I've seen that happen. But yeah. Oh, look, yeah. Elizabeth is saying endomethacin. Yep, I forgot endomethacin. Very good call. They do recommend that, especially to decrease that inflammation, especially for those older babies. Yes.
Okay.
Yes. Sorry, Elizabeth. I forgot about that one. You caught me on that one. Yeah. So, but I think otherwise. Oh, labetalol is 300 milligrams IV. The 2400's PO. Hydralazine is 20 milligrams max.
Oh, wait. You said it's 300 max?
300 milligrams, and that's IV. And it's 2400 PO.
Okay. And hydral was what?
20 milligrams.
20.
This is as per the practice bulletin.
Okay.
I think arrest of dilation is not a term they like. It's preferable to say arrest of the active phase or arrest of the first stage of labor.
Okay.
Okay.
What
And
about-
when you give endomethacin, it's only for 48 hours. You give like
Okay.
a 50 milligram and then you decrease it to 25. And I think it's every 8 hours. I would have to double check that. But you don't exceed like 48 hours worth of use, and you have to give it under 32 weeks because of the issues with the ductus. Okay, yes, every 8 hours and not given after 32 weeks. Now, Ruth is saying misoprostol is a PGE1.
Oh, okay.
You know, to be honest with you, I'd have to look that up. I don't remember. I don't even remember what you said.
I said 2.
2, okay.
I think that could be the other one, Cervidil, that we didn't have.
Right, it's very expensive. That's why some
Yeah.
places don't have it. I'm trying to think anything else. No, I mean, for being an REI, you know, I asked you some basic questions that sometimes people struggle with, and I thought you did well.
What about the Bishop's thing?
Oh, Bishop score. Okay, yeah, Bishop. So a score of greater than 8 indicates the likelihood of a vaginal delivery is similar to spontaneous labor.
Okay.
That's the true definition of a Bishop score.
Okay. All right. Thank you.
And then Vinny is saying ACOG says endomethacin is 50 milligrams loading, then 25 milligrams every 6 hours. Cool. And again, you don't exceed 48 hours worth of use. Okay. All right. Well, good job,
Thanks.
Alexandria. Okay. So Emily, I'm going in your direction. Emily R. It says you're self-muted. And Erica, you'll be following next because you're like down next to each other. You there, Emily?
I am. Can you hear me okay?
Yep, we're good. Generalist or subspecialist?
Subspecialist,
What do you do?
MFM.
All right. So GYN or office, right?
Yeah, either one.
You want a specific case you're worried about? Or topic? What are you looking for?
I haven't really reviewed GYN as much, so we could start there.
With a particular case?
I have a couple of ectopics and I have some BRCA on both of my cases, but really anything.
Did you submit your list? Because it's not here.
Oh, it's not?
You're under a different last name?
I shouldn't be.
And R, you're not here. Robinson, Rodriguez, Rolf, Roseberry, and Ruben. That's the R's we have.
Okay.
You're not here. You're not here. Can you look under E's just in case they put it under your first name? But I don't see it. Nope. Don't see it. I'll give you a topic though.
Okay.
You said GYN?
Yeah.
So I wish I had your list because I'm here. Like in what regards did you have the BRCA on your list? On your GYN list?
I have a patient that had ERPR receptor positive breast cancer and a BRCA2 mutation and underwent a risk reducing robotic TLH BSO cystoscopy and pelvic washings.
So how do you do a risk reducing?
So
BSO.
when doing when doing a risk-reducing BSO, after entry into the abdominal cavity laparoscopically, I do pelvic washings, and then I identify where the ureter is, and
So how do you do that?
I look in the pelvic sidewall and look for the ureter vermiculating.
So where in the pelvic sidewall?
It runs lateral to medial across the psoas.
So you look at it
Before-
all the way up there.
Or after entering the pelvic brim, it goes posterior to the ovarian fossa, and then it travels towards the bladder. So I would look posterior to the ovarian fossa.
Say that again, I'm so sorry.
I would look posterior from the IP ligament.
Posterior to the IP ligament. So what is the importance or the thing you need to do in regards to doing this risk reducing BSO?
So I take the ovary 2 centimeters proximal to the last visible ovarian tissue.
So let me ask you this. So you're saying you're looking at the ureter by the ovarian fossa. Is that what you said?
I want to make sure that I'm not taking the ureter.
Exactly. So how do you clearly identify the ureter in order to get that margin you're looking for your risk reducing BSO?
So if the ureter is close by, I can make an incision in the pelvic sidewall to drop the ureter down.
And you do that often?
I did that more as a resident than as an MFM fellow.
Gotcha. So let's say you were doing an abdominal hysterectomy. We're not doing anything robotic. How would you identify the ureter? Very clear.
So during an abdominal hysterectomy, I can separate the broad, like the anterior and posterior leaves of the broad ligament, and
where would you do that?
I would take the round and then I separate them there.
And where would you find the ureter?
In the medial leaf of the broad ligament.
So would that be of any benefit in identifying and isolating the IP up to 2 centimeters from the sidewall?
Yes.
So would that be a better way of doing it than, I don't know, making a cut in the pelvic sidewall? I don't know what you were discussing there.
Yes, it would.
Residency. So did you really do that in residency? I'm just asking. I don't know.
Occasionally the oncs would have me do that.
Okay. What else in a risk reducing? Did you have to do a hysterectomy in a risk reducing BSO?
No, you do not.
So why did she have a hysterectomy?
She had a hysterectomy because if they wanted, because she was on tamoxifen and she didn't want a second surgery.
So what's the issue with tamoxifen?
So it increases the risk of endometrial hyperplasia or dysplasia or cancer.
And how does it do that, or why?
I don't recall. but I think it has to do something with increasing, actually, I don't know.
So do you know what type of class of drug tamoxifen is?
A SERM?
So what would a SERM, that particular SERM do in the breast and that particular SERM do in the uterus?
It downregulates in the breast and upregulates in the uterus.
Anything else you would do in your risk reducing procedure?
So I would tell the pathologist that this was a risk reducing surgery, and I would ask them to do thin slicing on the fallopian tubes and thin, yeah.
So what exactly is BRCA?
BRCA is a oncogene.
What does that mean?
It is it's a mutation that can be carried that increases the patient's risk for different types of cancer, most commonly breast or ovarian cancer.
And how's it inherited?
Autosomal dominant.
And can you tell me what chromosome it's mapped to?
So BRCA2 is on chromosome 13. And
And what about
BRCA1
one?
on chromosome 17.
And what's the risk of breast cancer with BRCA1?
70%.
And two?
70%.
Ovarian cancer for one.
40%, and 2 is 20%.
So what is recommended, for example, in a patient with BRCA1 for management?
BRCA1, it's recommended to do a risk-reducing BSO after childbearing between ages 35 to 40.
And what about BRCA2?
The same procedure should be done between 40 and 45.
Okay, let's stop there. What'd you think?
I still have some more reviewing to go through.
No, I thought you did pretty good.
Okay.
So this thing about cutting on the pelvic sidewall, that's truthful? Because I don't even know where you'd be cutting. I'm just being honest.
I think I'm describing it incorrectly.
How would you describe it?
We used to like make an incision so that in the peritoneum, so it like dropped down the ureter, but I'm describing it wrong. So I will look through the operative.
Because the easiest way would be to go where the round ligament is, and you enter the broad ligament, and you use your yanker, and then the flip side end of your pickups, and you move up and down, and you will find the ureter on the medial leaf of the broad ligament, and at that point you can isolate the IP, get that filmy tissue out of the way, so to speak, and you could just clearly see the ureter is away from that area.
Yeah.
Okay. Yeah, you do not have to do a hysterectomy. In the old days, they thought you had to do a complete corneal resection. But that's been shown that you take as much of the fallopian tube out, but any typically fallopian tube left behind, the interstitial portion left behind after a BSO, there have been no reports of malignant transformation in the tubal remnant after this type of surgery. Okay, don't forget to do your pelvic washings. The ovarian artery and vein should be clamped and cut at least 2 centimeters proximal to the ovary, and preferably at the pelvic brim, to avoid leaving any ovarian tissue behind. Okay, and you can remove as much of that fallopian tube as possible. You want to carefully survey the abdomen and do your peritoneal washings. BRCA is a cancer suppressor gene, and you got a mutation in that, so you're not suppressing it. Autosomal dominant, BRCA1 is 17q, BRCA2 is 13q, and usually for BRCA1, you want to do your oophorectomy by the age of 40 and your BRCA2 by the age of 45 or complete of childbearing. So questions on that?
Okay. No, that was
Make
good.
sense?
Yeah.
No, very nice. I wish I just make sure touch base with the office because it's not here unless it's under
Okay.
a different name. Okay, there's only a couple of R names, which is weird. There should be a lot more R names.
All right. I will touch base with them. Thank you so much.
Okay, no worries. Good job.
Thanks.
All right, Erica, I'm going in your direction. Says you're self-muted. There you are.
Oh.
Hey, how we doing? I'm just gonna make sure I don't have any questions here.
Mhm.
Let me make sure. Hold on. So then Alexandria is saying you can open the retroperitoneal parallel to the IP and do it that way. Only oncs do this. But do they cut into this pelvic sidewall? I don't know. I've never seen them do that. But oncologists do different things. Every oncologist is different. Now, Janelle is saying, would you go for the rounding if you're not doing a his? If it's just a BSO, you actually go with in the filmy tissue in between the round and the utero-ovarian ligament in that area. If you're going to keep the uterus. And then, would you be able to verbalize the technique for identifying uterus for laparoscopic resection of 2 centimeter proximal to visible ovarian tissue? I mean, the way I think of it in my mind, and you should be able to do it laparoscopically, would be to literally go through that, that filmy tissue in between the round and the uterovarian. And I know an onc that does it just like that, and he identifies the ureter that way. So then Christine is saying, you elevate the peritoneal parallel to the IP ligament from the round ligament. Right, kind of like that filmy tissue there. Yeah. Everybody's putting questions here. Hold on a second, Erica.
Mhm.
Maybe I'm wrong, but can't you just see the uterus as it courses downward, mostly by the cardinal ligaments? This would be like, you can, but the issue here, and this is Andrea, you want to get as much down to the pelvic sidewall as possible so you could be hitting the ureter. That's the key about a risk reducing BSO. You want to get as much, you don't want to leave any tissue behind. So that's why you have to identify the ureter. Some people don't feel comfortable doing that, so they'll refer the patient to the oncologist. So but you may leave because are you going to be 100% sure you're getting you're not going to be damaging the ureter? So if you can identify the ureter away from that IP really, really well, then you can clamp it towards that sidewall. Am I making sense, Andrea? See, but the thing is, like, unfortunately, now that they do a lot of things laparoscopically, they don't identify the ureter very well. It's just visualizing. That's why you all do cystoscopies, right? But for the risk reducing, you should identify the ureter extremely well in order to do the proper surgery for the patient. Again, I'm not an oncologist. So ideally, you could take the round at its attachment to the side wall. This is somebody is writing. Let's see who's writing this. Hold on. Because people are just blowing up the questions here. And this is Jared. To the side wall, go parallel to the IP and also open part of the anterior leaf of the broad ligament. The ureter lies on the medial leaf. If you can't find it there, you can find it higher up in the bifurcation. That is correct. But the easiest place, in my opinion, is where you have that area between the round and the uterovarian, that filmy tissue, and you can just see it on that medial leaf. And then you can clearly see the IP, hopefully separate from, or a good distance from that ureter, and you can just then, transect it high up. And then it says here, you develop a space with suction. That's the best way to identify the uterus. Yeah, use the other side of your yanker and your pickup. And you're saying, ah, I see. Thanks. Well, I think she figured it out. Hopefully, discussing it. Okay, if you are in the correct space, the yellow fat will go to the side wall. You can do a lot of this with gentle blunt dissection when you are in the correct space. That is correct. That's from Jared. And then you can certainly make the window above the ureter and below the IP, and then take the 2 centimeters needed. Exactly. I don't know if I'm explaining it right. Again, I'm not an oncologist. But the key here to just say I'm looking at the sidewall and just take a look at it. No, you definitely have to isolate the IP separate from the ureter, in my opinion. So I think if you have a risk reducing procedure on your case list, that could be something that they could bring up, because that brings up your anatomy and all that good stuff, right? So I think that's a good question in this type of case. So hopefully that answers everybody's questions. Again, I'm not an oncologist, but nowadays we don't identify. We take a look at the ureter, but in the old days we identified it completely, especially in our abdominal hysterectomy. So I guess I'm aging myself. Now you just take a look at, oh, it looks good, and then we do your cystoscopy at the end. You really cannot do that in this type of risk reducing procedure. You gotta really isolate it to do that proper procedure for the patient, because you don't want to leave any tissue behind. God forbid she has a microinvasive issue later on, if you left some cells or something of the ovary. Okay, so hopefully that helps, answers everybody's questions. Okay, I think we've answered everything. If I didn't answer something, please just put it in the box and we'll get to it. You there, Erica?
Yeah.
Generalist or subspecialist?
Urogyn fellow.
Urogyn. Any suggestions? Here we go. We got Urogyn on the phone. Any suggestions? Any suggestions in regards to identifying that ureter?
Yeah, I mean, kind of like what everyone was saying. Like if you are separating the, or if you are going to divide the round, start there. But if not, you can just go below and make the window, like everyone was saying. I agree with a lot of what people were writing in the comments.
In regard to, you mean below the IP? Is that what you mean?
Yeah, like making the window below the IP above the ureter.
Man, I'd be scared. I'd be scared to go there. And have you heard of people cutting the pelvic
like,
wall?
sorry, I was trying to not get into it too much. I'm just agreeing with what people wrote in the chat. Yes.
Maybe I'm just chicken. I think that area where the tissue is in the round and the uterovarian right there, you can see the ureter very nicely.
That's what I meant, and then I meant you're going to open it up, identify the ureter, and then make the window before you take your
Exactly. So
anyway,
like the gal that said, well, you could do it at the oncs cut the pelvic sidewall. I don't know where they cut, so I can't comment. I'm not an oncologist. I'd be scared. But yeah, they can fix the problems, right? I don't want to make the problem and then call them to fix it, right? Cool. But I think it's a good anatomy point. And, when you talk about the ureter, I could see questions on risk reducing BSO for sure. Anything else you'd add there, Erica?
No.
Okay. A specific case, I'm assuming you're looking for what?
I have a GYN case.
Hold on, let's take a look at it. Hold on.
Case number 18.
Hold on, let's look for it here. No, I'll turn the screen on here in a second.
Yeah. It's not so much like knowledge about it, but just the details of the case, and I don't know. I would like to practice answering some questions about how the case kind of went, I guess.
Okay. So you want to present the case for us? You said 18, sure. Correct?
Yes. So this is a 47-year-old female who was originally seen by a general GYN, complaining of some abnormal uterine bleeding, mostly just heavy but regular menses, and some pelvic pain. She had an ultrasound done that did show a 4-centimeter exophytic fibroid. She had also reported to that GYN some urinary incontinence. She and the gynecologist had made a plan to perform a hysterectomy for sort of bulk symptoms and her AUB, and she was referred to urogynecology for the incontinence. I had made a plan to do a sling with her, and we basically end a joint case sort of with the gynecologist. I had discussed with the patient.
Let me interject here. Let me
Yeah.
interject here. When you say joint case, the gynecologist was going to do the TVH, and you were going to do the uterosacral ligament suspension and the sling?
Yes, and be available and present for help if needed for the TVH.
So what decisions or what, why was the decision made to do a TVH? Like, why did you guys feel she was a good candidate for that?
So it was felt that despite the fibroid, her uterus was not very large. She had see, this is honestly where I'm struggling, because to be honest, as a fellow, I did not see her preoperatively. My attending did, and just to be honest, I'm sort of like sidebarring with you right now. When I did her pelvic exam, like when she was asleep in the operating room, I was personally sort of surprised that we were going to do a TVH.
And what surprised you on the exam?
I didn't feel like she had much dissensus.
And but she had 3 prior C-sections. Wow, that's bold. Okay.
Yeah. Yeah. So,
and is that the reason she was opened up and converted, because of the descent? Like where was
Right.
it messed up and we got to open her? Because I'm assuming that she started bleeding and she needed the transfusion, right?
Right. Yeah. So in brief, we started the surgery and we were able to enter the peritoneal cavity posteriorly, but we're having difficulty anteriorly. So we just took we dissected the bladder off. We took a few bites.
Can you do me a favor here? Can you,
Yeah.
seeing that you're a urogynecologist, can you explain, because you have a lot of vaginal hysterectomies on your case list. Can you
Sure.
explain, because I think this is an important point. Can you explain to everybody on the call, specifically, if you cannot enter anteriorly, what you need to do? Because I can see them asking questions in regards to this, because a lot of people don't do vaginal hysterectomies. So
Yeah.
they're going to make it difficult. And then because a lot of people on the call are not experienced with vaginal hysterectomies, and they're going to say, well, I just don't know. So do you mind going through that kind of slow? So as from a urogynecologist perspective, everybody, I'd be listening really well.
Yeah,
Go ahead.
absolutely. Okay, so I usually start off my vaginal hysterectomies trying to enter anteriorly, and the important things there are traction on the cervix and then upward traction on the vagina to really sort of demonstrate those vertical fibers for me. And if I'm having a lot of bleeding, if the tissue feels sort of hard, I know that I'm erring towards the side of the cervix. And in general, I do find that you're always cutting a little higher than you think you should. And if you're having trouble, then more traction to separate those layers better can help out a lot. If I'm having trouble after a few cuts, I just go ahead and enter posteriorly. At this point, I've probably dissected my bladder off of the cervix enough to be able to take my Haney, clamp my uterosacrals, cut them. That gives me a little bit more ability.
Let me interject here. Do you hear what she's saying, everybody on the call? So when you have difficulty starting anteriorly, you can start the process posteriorly, but you make sure your bladder is moved up, and you can start doing, remember, you do the uterosacrals first. I've had people in my mock oral say, oh, I go straight to the uterines. I go, no, you're going backwards. You get the uterosacral. I know when you do a TLH, everybody forgets about the uterosacrals. You tag the uterosacrals and that those are left for later on in the case, so you can do a suspension if you needed to or anything. And you can literally start your case that way, as long as that bladder is moved up. And then hopefully you can kind of put your finger, if it's a small uterus, around the fundus and kind of delineate where that plane you should be going to. Because remember, if you go into the bladder in that area as you're going in anteriorly, where are you going to hit? You're going to hit a very critical part of the bladder, which is the trigone. You'll be calling her to come in and help you out. But you continue, Erica.
Yeah. So exactly. I'll take my uterosacrals. That gives me a little bit more ability to pull down on the cervix, and that usually will give you a little bit more traction to open, to delineate that anterior space. And when I take those bites, I have a deaver or something anteriorly to help push the bladder back. And I'm very careful about not going too anterior towards the bladder when I do that. But basically, it's just a matter of having good traction. I'll use pickups to kind of help me, even have another assistant holding the deaver, and then pickups to even like kind of help me even more with that traction. And then also being sure not to sort of dig myself in a hole, kind of treading the fine line between making my cuts, still in the middle so that I don't run into vasculature, but sort of not, making them big enough so that way I am not digging into a tiny little, half centimeter hole where I can't see anything. And then, yeah, exactly. My uteruses are often small. And so I'm often able to, hook my finger around the uterus and use that to really delineate where I need to be, and almost even like cut right over my finger, knowing that the bladder is above.
Okay, so hopefully that clarifies things in everybody's mind in regards to tackling the TVH, because that's very important. Because what I'll do in a mock oral, I'll say, well, you're having problems going in anteriorly, what would you do? And I've been told, okay, I'm just opening her up. I'm like, okay. So where did she start bleeding? Was it at the uterine in a specific place on one specific side?
Yeah, so I think what
from the fibroid, because it was hard to identify because of the fibroid?
No, so what happened was we just couldn't enter anteriorly. We started to notice that even though we had taken some bites and we were expecting more descensus, our uterus really was not coming down anymore. And we were encountering like thick tissue, couldn't really find a good plane where we were seeing more filmy tissue anteriorly where we would expect it. And so we then had significant concern that she had sort of dense adhesions from her prior cesarean sections, and made the decision to proceed with laparotomy.
And there was no consideration for like a TLH or LAVH,
The amount of adhesions that we were sort of expecting made us feel that a TH might be a safer bet in terms of knowing that we could complete the surgery in that way. And additionally, there was not going to be a quick way to get laparoscopic instruments.
Okay, so it wasn't prepped. So I guess at that facility, if you move from a TVH, you go directly to a TH.
Yes, correct. That's a good way to put it. In this case, we did not have a laparoscopic setup quickly available, and it was much quicker for us to get.
Now, when you went in, was she bleeding from what you did from below, or no?
Right. So that's basically, I think, the reason that she had the blood transfusion is because just as we were sort of setting up to enter abdominally, there was bleeding, from the cuff, from the side of the uterus. There was not a particular pedicle, but just, bleeding from our incisions. And when we entered abdominally, we did a fan and seal and ran into some dense adhesions. In fact, the uterus was adherent to her anterior abdominal wall. So it took us a while to get to the point where we actually...
And your attending didn't feel that? I mean, that's pretty... What was her BMI?
Her BMI was not severely, I can't remember, but it was not like...
So she was not like... If you were able to palpate it, you were like, why are we doing this? Because there's no way you would have been able to have gotten to that. That would have been tough.
Yeah.
If it was adhered all the way to the abdominal wall. So it was kind of like one of those uteruses that was elongated because of the adhesion. You know how the uterus changes its shape?
Yep, exactly.
Yeah. Okay. So how would you have taken that out vaginally then? Might have been tough.
So that's kind of why I've asked you about this case, because yes, exactly. I don't know why
You
that
know,
was not really.
because it is on your list. You got to own it,
I know. Yes.
right? You got
So,
to own it. And so I'm trying to think what's a nice way to, because
yeah.
I'm gonna go. I want to see. Oh man, I just lost it.
I mean, I mean, I'm a fellow. It's clear that I'm a fellow based on my list and everything. Like,
Yeah, but it's on your list. You got to own it. That's the thing. Let's think a second.
yeah.
Oof. I mean, I mean, you're gonna have to say if they ask you about this particular case, you'd have to defer it to your attending.
Yeah.
And you have to be honest. I examined this patient. She had the previous 3 C-sections, and I kind of felt that it was going to be a difficult case, but I felt that I was going to learn a lot from my attending, and it ended up being having to be opened up, especially if she's adhered to the anterior abdominal wall. You're not going to be able. I mean, that's going to be a tough one in order to be able to do it vaginally.
Yeah, I don't know how we would have done it. I mean, I don't know how you could do it like that, because I mean, it wasn't.
And
It was like the
he
whole
particularly examined her.
What was that? Sorry.
And he specifically examined her. It wasn't another attending.
Yes, correct. She did.
Wow. Okay. How much did she lose? PBO?
Oh shoot, I don't remember off the top of my head. I want to say it was at least 500.
Ooh, okay.
Yeah.
So she got like a unit or something.
Yes, she did. Yes.
For the abdominal bilateral uterosacral ligament suspension, did you go all the way up to the spine, or she didn't have to go that high? This was more prophylactic.
It was more prophylactic. We noticed
so
once
for prophylactic, how far up would you go?
we still go to at the level of the ischial spine.
Though you go that high?
Mm-hmm. Yes.
So as a urogynecologist, because I have you on the phone, now I'm going to pick your brain. Because I know we always say about the sacrospinous ligament fixation as well as the abdominal sacrocolpoplexy, and I know a lot of urogynecologists now are doing uterosacral ligament suspensions all as treatment. But a uterosacral ligament suspension can be done as prophylaxis.
I guess I don't want to say prophylaxis in this way. I want to say that, preoperatively, we did not see her preoperative POP-Q did not demonstrate significant prolapse. However, once the uterus was out and, since it was adhesed to the anterior abdominal wall, there was
held up by all adhesions, right? It was being held up by all the adhesions.
There was a lot of laxity of the uterus when the cuff was closed. The cuff was sort of lower than you would typically have it, and so we felt that she would benefit from the uterosacral.
And what suture do you use?
In
uterosacral?
My practice, I use zero vicryl, but it would also be reasonable to use a non-absorbable suture like a Proline.
They would do Proline. Okay, and how many passes do you do?
I generally will put 3 stitches through the uterosacral ligament, and then
are you moving it more towards the more of the midline of the cuff as you move it along?
Yes, correct.
Okay.
Yeah, your highest stitch is going to be the most lateral, and then your most.
And then you move it a little bit lower, and
medial.
it's okay. Gotcha. So it's like a little triangle, for lack of a better word.
Okay. Yeah.
And on God's green earth, you would never do a McCall? Because I know a lot of urogynecologists are not very keen on McCalls, or am I incorrect with that?
I have done McCalls.
Okay.
Yes, I have done McCalls. They probably do not cause as much. They do not give as much apical support, but I can think of one case where we had a patient who had a very long cervix. And once that was out of the way, she didn't really have, much prolapse of her apex. So we just helped to re-support that with the McCalls.
And so for everybody on the call, the difference between the uterosacral ligament suspension and a McCall is the McCall plicates the uterosacral in the midline, while the uterosacral, it's to the ipsilateral cuff angle. Very important. So I know that's why I thought, maybe my misinterpretation, that some urogynecologists don't like the McCall because it's anatomically incorrect. So they worry about dyspareunia and stuff like that.
I'm not sure. I'm not sure.
Okay.
Actually, that's a good thing for me to
That's
look
what I
into.
read. That's what I read once, and I'm like, because I trained with a McCall. I never had seen a uterosacral ligament suspension ever.
Yeah.
So, so I'm trying to think any other questions in regards to the case. I think you're gonna have to be honest. If this case is brought to the light, you have a lot of cases. You have 38-page list, so they may not see this.
Yeah,
But you do have blood transfusion, so it is like a complication there. I think you're gonna have to be honest. And you know, my attending, I was in fellowship at the time, felt that this could be done vaginally. But of course, I mean, I don't know how you could not have felt that this was adhered to the anterior abdominal wall. I'm kind of shocked on that one.
Yeah. I can't say. And then the other thing about this case is that she was reporting some abnormal uterine bleeding and she was 47, and the
No
general
EMB?
gynecologist did not do a biopsy, whereas in my practice I would have, but I think I
Right.
will just say in my practice this patient would have gotten an endometrial
Right.
biopsy preoperatively
Right.
because she's
Is that
over
correct?
45.
Of course, that's standard of care.
Yeah. So I will just that I feel okay with.
If
I'll
it's
just phrase
noticed,
it, like,
if it's
in my
noticed,
practice.
if it's noticed, for sure. Okay. No, I think it's fine. Interesting. And thank you for answering questions. And, you know, because a lot of people are very fearful of the TVH, urogynecology, because, you know, these are the questions that everybody runs away from.
Yeah.
Let me see if anybody has any questions, because I got you on the line. It'll be my go-to urogynecologist.
Sounds good.
Okay, let's see what we got. Okay, here we go. We got a lot of stuff here. Okay, stay on the call. Wow. Okay, hold on. Hold on, let me see here. Okay. Okay, would you be an advocate for backfilling the bladder? Be a helpful technique for anterior entry?
Oh yeah, absolutely. I mean, don't hesitate to backfill if you feel like you're not sure if you're close to the bladder. Absolutely.
That's from Hannah, but sometimes you still don't know where to go. And I'm
Yeah.
assuming in this case, it would be difficult because of the previous cesareans.
Exactly.
Okay. You could say you were at intraop consult, Alexandria's saying. There you go. You're not supposed to lie on the exam, but I don't think this is that bad of a thing. You just say, hey, this is what my attending did. I kind of examined the patient, you know, did the EUA. I was kind of like, okay. And I wasn't surprised. And I learned a lot in this case by da-da-da-da-da-da, you know.
Yeah, exactly. Okay, yeah. I mean, it is
And
the
yet
truth.
she wrote, which you kind of were. Okay, yeah, good point, Alexandria. So
Yeah.
you didn't plan the case. There you go. All right. So it says here, this is from Lee. I'm a generalist in general practice, and I have some HISs that are LAVH and some that are robotic. Do you think that examiners would ask about that? I would say that the LAVH I do with my partner, robotic I scheduled when she was not available, lack of a skilled assistant. One of my robot HIS has 3 prior C-sections, so I could talk about that. Can you comment, please? Yeah, I mean, you got to be honest in what you decided. I know some people, they do everything robotic because of the issue of having an assistant. Some people do robotics because they needed the case in order to get certified in doing the robotic. Of course, they want everything minimally invasive if possible. So I just would be honest, if my partner's there, I'll do an LAVH. If she's going to be out of town or whatever, I feel more comfortable doing the robot because I have a steady assist or whatever you want to call it. I don't see anything wrong with that, because you still got that minimally invasive procedure. So hopefully that answers your question there, Lee. And then Andrea, can you tell us which procedures are used for prophylaxis to avoid future prolapse versus those that are placed for treatment? So for treatment, correct me if I'm wrong, Erica, would be treatment. So you have apical prolapse. So she has uterine prolapse. You just don't take out the uterus and say, have a good day, everything's done. No, you have to do something in order to support that vault. So that would be a sacrospinous ligament fixation. That will be a abdominal sacrocolpoplexy, robotic colpoplexy, or laparoscopic. It's an open technique, for lack of a better word. The sacral vaginal and the uterosacral ligament suspension. Correct me if I'm wrong, Erica. That could be done abdominal. That can be done vaginal. Correct.
Correct. Yep, the uterosacral, either way. Laparoscopic
So-
too, or
so
robotic,
those,
if you needed to.
those, yeah, exactly. Those three are treatment. Prophylactic would be the macaw,
Mhm.
and then the uterosacral ligament
Mhm.
suspension. Okay, so hopefully that answers your question, Andrea. How do you choose between the SSF and the uterosacral ligament suspension? I think it's just experience of the surgeon. SSFs is a blind procedure. Do you do SSFs, Erica?
Yeah.
Okay.
So a lot of people will not do a uterosacral ligament suspension after someone's already had a hysterectomy if they're doing it vaginally, because that would require you to re-enter the peritoneal cavity, and you could you often have adhesions at the cuff and things like that, and so it's a higher risk for a bowel injury.
Good point.
So a lot of people, if someone has already had a hyst, they'll do the sacrospinous, or if someone wants to keep their uterus for whatever reason, you can do a sacrospinous vaginally for hysteropexy.
And what would you tie to the ligament?
You
With the
would
uterus in
put your
place.
suture, you sort of have to dissect, you obviously have to open the vaginal epithelium, and you sort of take that all the way up to the cervix level so that you actually bury your stitch more in the like vaginal muscularis and cervix, and then you're going to close your vaginal epithelium over that. And you would usually just do that unilateral.
So you're suturing what to what if you still have the uterus in place? Like the cervix?
So
I can't imagine it. I'm here like thinking about it. Because
yeah,
you'll go in posteriorly, right?
correct.
Right. You have to go posterior. You're going down. Yeah, even I know that.
So you open the vaginal epithelium, you dissect it off the muscularis below. You're gonna put your stitch in at your sacrospinous ligament, and then you're going to anchor that sort of to the vaginal muscularis that's right at the cuff, right at the cervix, or even into the cervix a little bit.
A little bit to cervix. Okay, cool. I've never heard that. Okay, cool. Cool, awesome. And then you can also put a probe in the urethra to the bladder if you can't get in anteriorly. You can, Andrea, but I think in the case that Erica has, it was going to be a lost cause. I really do think that she was going to be opened up no matter what you did. Because those adhesions, if you have if you have the uterus attached to the abdominal wall, you're not going to be able to get to that.
No, yeah.
You can't, no matter, you can't get, sometimes you can pull it off with a small uterus. I once did a case where I was able just to enter posteriorly, and it was such a small uterus, like with my finger, I just did the anterior with a finger. I just broke it up, and the uterus came. There's no way this would happen in this case because it was sort of cured high up. Okay.
No, correct.
All righty. So does that answer your question? Thank you for me to be peppering you with questions or urogyn, because I know that's something a lot of people get nervous about.
But it's good. It's good practice for me too, also to explain these things. So it's good.
Yeah, I mean, because they're going to treat you like a generalist, and they're not going to treat you like a subspecialist, because this is the generalist exams.
Yep.
So in that case, yeah, you're going to have to say, yeah, the decision was made by someone else. So, and that's a good point what Alexandria said. Good point that you were a consultant.
Yes. Yeah. Yeah. Exactly.
What's that famous? I just heard this recently. What's the famous comment? How do you cause problems with the ureter? Call a gynecologist. I never had heard it. I'm like, really? They think we're that stupid? Okay, perhaps.
Colorectal gets them too. It's not just us.
Yeah. Any other questions? But thank you for letting me pepper you. Appreciate it.
Yeah, no problem.
Great job on your presentation. So I think you're going to be fine if they notice this case.
Thank you.
Yeah. Okay. Awesome.
Yeah.
All right, Eva, I'm going in your direction. It says you're self-muted. Oh, there you are.
Hi there.
Hi, how's it going?
Good. How are you?
Generalist or subspecialist?
Generalist.
Okay. You have a specific case that's worrying you, or
No,
topic?
any.
What are you looking for?
I think any would be fine. I know we're going beyond the time.
I always go over. I always go over. And everybody, some people like it. They get off the call. People got to take care of the kids, put them to sleep, whatever.
Yeah. Yeah.
What section bothers you? What you looking
I
for?
haven't done OB or office in a bit, so any of the two.
What have we done more? Because I don't recall what I've even discussed with some people today. What have we
We
have
did
discussed?
everything. I think we did every category.
Let me look at your office, see what we got.
Sure.
Let's see if something pops up that sounds interesting. Gets to a point, it's kind of the same thing over and over again.
I know. I will say my
A little
office
bit.
is
Yeah,
very bland.
we can make it concerning though. We can. You can do a lot of different things. I'm just looking.
Mhm.
Have you heard a lot of my webinars
I have, yeah.
by chance? You have? Because I don't want to give you something. Because I think it's a
Well,
topic that a lot of people.
mhm.
Famous last words. You want to amend that?
uh, I can't say that I retain every one of them, but
I'm sure you've heard me say this, but let's just go with this one. It just gets my attention. So case number 17.
mhm.
Okay. Can you discuss the growth phase of hair for me?
Yes. So with hirsutism specifically, you have the telogen phase. That's the terminal hair follicles. That's a concern.
Anything else in the growth phase?
I'm not. I can't recall the specific phases, but the telogen phase sticks out with respect to hirsutism.
So, if a patient has hirsutism, is there any specific workup you would do in order for further evaluation?
Sure. So I would, assess for her risk factors for PCOS, for hyperandrogenism, for any sort of medication use, and family history.
Can you give me a differential if somebody was hirsute?
It could be familial, is genetic component. It could be hyperandrogenism, PCOS, medication, like anabolic steroid use.
Anything else?
Some sort of androgen secreting tumor.
Anything else?
Like Cushing's potentially, virilization.
Anything else?
No, that's all I have for now.
Think about it. You're missing some.
I like the more metabolic component, like diabetes and things.
No. So if somebody is hirsute, what diagnostic test would you order for further evaluation?
I would order testosterone, free testosterone level, DHES, DHEA, check FSH, LH, estradiol, progesterone.
Anything else?
I would get a, focused history about her menstrual pattern, do a physical exam.
Anything else?
Is consider a pelvic ultrasound if I'm concerned about kind of ovulatory dysfunction or.
So can you give me another diagnosis other than PCOS that can give you ovulatory dysfunction? And it presents a lot like PCOS.
Just anovulatory dysfunction.
So what if I told you you should order a 17-hydroxyprogesterone?
Oh, congenital adrenal hyperplasia.
Sounds like something in the differential, correct?
Correct, yeah.
Okay. So going back to hirsutism. So what would be your first line of treatment? Let's say all her testing come back negative.
Sure. So if it's just hirsutism alone, she can do a trial. She could consider laser therapy, spirolactone, combination with combined hormone contraceptive.
So what's the mechanism of action of OCPs with regard to the hirsutism?
So it increases your sex hormone binding globulin and decreases the circulating androgens.
And what's the mechanism of action of spirolactone in regards to that hirsutism?
That I'm not sure. No.
Okay. And let's say you started somebody on the spirolactone. In what time frame would you see maximum benefit?
Spirolactone generally takes about 3 months, I believe, to for maximum benefit.
So how's hirsutism objectively evaluated?
So you would, I guess, assess the thickness of the hair follicles, and they're generally thicker, being terminal hairs, and you would assess the distribution of them. Examine like the location, or and it's usually in a chin distribution.
Is there a specific scale that's used?
I'm sure there is. I don't recall off the top of my head.
Okay. So let's say, going back to the patient who had an abnormal 17-hydroxyprogesterone, how would you manage a patient who has non-congenital adrenal hyperplasia?
So with non-congenital adrenal hyperplasia, I would I guess I would that I'm not sure.
All right, let's stop there. Not an easy topic, eh?
That's kind of a black box I've avoided so far.
What I recommend, this is what I've been telling in the webinars, especially in office, know something about all the different categories. They have PCOS, they have hirsutism, they have galactorrhea, topics that I personally hate, but it makes you think, good questions come from those, And then, what causes hirsutism? Cushing's, an androgen secreting tumor, non-congenital adrenal hyperplasia, that type of thing. And I remember when I was sitting for the exam or taking the exam or studying for the exam, I did the webinars just like you guys. And I remember one of the faculty's like, well, what's the growth phase of hair? I sat there and go, I never even thought about that. I never even got asked that question. I never even looked at it. I freaked out. I'm like, oh my gosh, I don't know this. I got to read it. So it was from the Exam Pro. Because I never even thought about the growth phase of hair. You just have hair. You know, I guess I didn't have a really good dermatology rotation. So I was like, oh my gosh, I got to read that. So the growth phase of hair: anagens, primary growth phase, majority time hair spans; catagen, the hair follicle involutes; telogen, the resting phase that lasts several months. Hair sheds at that stage. Okay, in regards to, you were correct with the OCPs, it increases the sex hormone binding globulin, thus decreasing free testosterone. Okay, spirolactone decreases ovarian adrenal production of androgens. It decreases dihydrotestosterone by inhibiting 5-alpha reductase. So in what time would you see maximum benefit? They say 6 months. So if a patient starts a medication, she shows up 2 months later, I'm not happy, she has to buy, you know, because you have to go through the growth phase of hair, right? You have to wait for it to kind of kick in. And plus, sometimes when those coarse hairs have grown, it's the future hairs that won't develop, okay? So how is hirsutism objectively evaluated? It's the Ferryman-Galway score. And that's when the chin and the chest and all that comes into play. That's the name of the scale, or whatever you want to call it. So patient has hirsutism. I thought your differential was great, other than missing the non-congenital adrenal hyperplasia. So Cushing syndrome, androgen secreting tumor, medications like danazol, DHEA, testosterone. Skin-to-skin contact. If you have a partner who uses like some testosterone cream or something, possible. Ethnicity also, and that could be just normal because of your ethnic group. It's very similar presentation to PCOS. So initially treatment would be to put her on the birth control pill, kind of like PCOS. Okay. However, if she wants to get pregnant, then the recommendation would be to start her on some glucocorticoid therapy as initial treatment for ovulation induction, because you can't really give steroids long term, right? Because you have a lot of side effects, correct? So if she's trying to get pregnant, then you would use the steroids to assist with ovulation induction, and you can add Clomid if it's ineffective. So you begin with prednisone 5 milligrams daily, which can be increased to 7.5 milligrams daily before adding the Clomid. Okay. But remember, you know, the steroids do have some major consequences for long-term use. So that's why you would put her on OCPs, and if she wants to get pregnant, then you proceed with, if you want to give her the steroids, and go from there. Okay. So questions on that? Not an easy topic. I personally don't like it.
No, thank you. Thank you very much.
Yeah, no, good job. Good job. All righty. So I'm just going to see if anybody has any questions before we wind the call. Okay, so Jennifer wants repeat the growth phase of hair. So anagens, the primary growth phase, that's the majority time hair spans; catagen, hair follicle involutes; and telogen, resting phase that lasts several months. Hair sheds at this stage. And the mechanism of action, spirolactone, it decreases ovarian adrenal production of androgens. It decreases dihydrotestosterone by inhibiting 5-alpha reductase. Okay, so hopefully that answers that question. So if anybody has any other questions, if you want to put it here on the question box. I think we had some good topics today. And I think the point of discussion of the vaginal hysterectomy, I know some people do not have many vaginal hysterectomies, or do not do or have any vaginal hysterectomies. A great question is, please dictate a vaginal hysterectomy. And it's hard to dictate somebody something if you really don't understand the process, because you didn't do much of it in residency. So hopefully that explanation that Erica gave, which was very nicely done, was beneficial. as well as the different procedures for treatment of apical prolapse and prophylaxis for apical prolapse. So I'm just staying here on the call for a couple more minutes. If anybody has any other questions before we wind everything down. I am going to stay on for a couple of minutes after I end the call. If anybody has just some private questions, I can answer you privately in regards to something specific on your list or anything in general in regards to study technique or what have you. But at this point, I want to thank everybody that participated today. The webinar, I think we had some good topics. I wish everybody good luck continuing in your studies, because I know we got a couple more weeks for the first group of November test takers, and then followed by the second group. So I know everybody's crunch time, and I'm wishing everybody good luck with their continued studies. And at this point, I'm going to wish everybody a good night, a good rest of a good week. And I think I'm on with you guys sometime next week. I can't remember what day. So I'll stay on the call. And if anybody has any questions, type them on in, and I can send an answer privately. And I wish everybody a good night. So thank you so much, and have a good night.